Assalamu alaikum warahmatullah. In this short video, we are going to explain the anticoagulation of a choice in a case of confirmed VTE, venous thromboembolism, especially in a case of DVT or PE, deep venous thrombosis or pulmonary embolism, which are the most common aspects or forms of venous thromboembolism. As you know, we have a lot of available anticoagulants, like oral anticoagulants, including warfarin, DOAC, which are a direct oral anticoagulation, including apixaban, doxaban, rivaroxaban, dabigatran. We have other injections of anticoagulants, including enoxaparin, tenzaparin, fondaparinux, and others. We are talking about the most common anticoagulant available. The question is, which anticoagulant of these we have to start on in a case of confirmed DVT or PE? We have a rule of 7, which means that we have 7 questions, and according to the replies of these questions, we can decide which anticoagulant of a choice or the first line of anticoagulation in the case. The first question is site of VTE. What is the site of VTE? Is it DVT? Is it PE? Is it deep venous thrombosis or pulmonary embolism? Is it Budd-Chiari syndrome, which is hepatic venous thrombosis? Is it CVT, central venous thrombosis? So, if the site of the thromboembolism is away from DVT or PE, at that time warfarin is the first choice. If you have a case of Budd-Chiari syndrome, hepatic venous thrombosis, or CVT, central venous thrombosis, the only choice available actually is a warfarin with bridging with Clexane until for 5 days or until INR is 2 to 3. DOAC is not licensed yet to be started with such condition in Budd-Chiari syndrome or central venous thrombosis. In the case of DVT or PE, DOAC is the first choice, either apixaban, doxaban, rivaroxaban, dabigatran. These are the first choice in the case of DVT or PE, if not contraindicated, of course. So this is the first question, the site of VTE. The second question is how the severity of VTE. In the case of massive PE, which is characterized by hemodynamic instability, including hypotension, desaturation, and hypoxia, engorged neck veins, a right-sided heart strain. In such condition of massive PE, thrombolysis is the first choice. Thrombolysis with alteplase, 100 milligram for 2 hours, infusion for 2 hours if no contraindication, or 50 milligram for 1 hour if there is relative contraindication. So thrombolysis is the first choice in the case of massive PE with hemodynamic instability, followed by heparin infusion, unfractionated heparin infusion with warfarin bridging. Okay, what if the ultrasound or CTPE revealed that the patient has extensive DVT or extensive PE? In such condition, DOAC is not the first choice. So the first choice in case of severe or extensive DVT or PE is either warfarin with bridging or Clexane 1 milligram per kg BD on the long term. So again, in a case of extensive PE or DVT, DOAC is not the first choice and not licensed in such condition. Only warfarin with bridging with Clexane for 5 days or until INR is 2 to 3, or Clexane 1 milligram per kg PD for 3 to 6 months according to the provoking factors is the first choice and only choice in cases of extensive PE or DVT. In the case of subsegmental PE or DVT, subsegmental PE or segmental or subsegmental with hemodynamic stability, at that time DOAC is the first choice, either apixaban, rivaroxaban, edoxaban, dabigatran, if not contraindicated. The third question is how the renal function test. Of course, you cannot start anticoagulation without checking the renal function test of the patient. In the case of severe renal impairment, where creatinine clearance is less than 15, all DOAC medication, direct oral anticoagulation, are contraindicated, and the only choice in such cases is warfarin with heparin infusion bridging for 5 days or until INR is 2 to 3. So warfarin is the only licensed medication in the case of severe renal impairment where creatinine clearance is less than 15. What if creatinine clearance is between 15 and 30? And in other trusts 15 to 50. If the creatinine clearance between 15 and 30, you can use DOAC, including Abexpan with a reduced dose, 2.5 mg BOPD instead of 5 mg BO 2 times daily, or edoxaban 30 mg BO once daily instead of 60 mg BO once daily. Other DOAC are contraindicated. So you can start DOAC with precaution in the case of renal impairment with creatinine clearance between 15 and 30, with reduced dose of Abexpan 2.5 mg BOPD or edoxaban 30 mg BO once daily. Of course, you can still use warfarin in such condition. What if GFR or creatinine clearance is more than 30? At that time, DOAC is the first choice. In one of the DOAC, including edoxaban, rivaroxaban, dabigatran, could be started on normal dose if GFR is more than 30. Okay. The fourth question is, what is the weight of the patient? This is very important question, and most of the physicians are ignoring, the weight of the patient while starting on anticoagulation. So in extremes of weight, like body weight is more than 120 kg or less than 50 kg, or BMI is more than 40, the first choice in such cases is either warfarin with bridging or Clexane as a long-term 1 mg per kg daily. So DOAC is not used at all and not licensed in the case of extremes of weight. Direct or oral anticoagulation, including dabigatran, rivaroxaban, edoxaban, are not licensed in the case of extremes of weight if weight of the patient is more than 100 kg, 120 kg, or less than 50 kg, or BMI is more than 40. The only choice in such cases is warfarin with bridging for 5 days or until INR is 2 to 3, or Clexane the long term. And of course, the preference of the patient is very important. You have to ask the patient about his preference of which anticoagulation he wants to start with. This is in the case of extreme of weight, according to a recent NICE guidelines in March 2020. The fifth question is risk of bleeding. If the patient has high risk of bleeding, for example, has previous history of major bleeding like hematemesis or melena or abageate bleeding or intracerebral hemorrhage, at that case, the choice of anticoagulation will be Clexane, which is enoxaparin 1 mg per kg BD. Why Clexane is the preferred anticoagulation in such cases? Because of the availability of protamine sulfate, which is the antidote, so that if the patient develops any bleeding anytime, it can be reversed easily with protamine sulfate, which is available in the hospital. Also, warfarin can be used in such cases because we have available prothrombin concentrate, which can reverse the effects of warfarin. But DOAC is not preferred in such patients at all with high risk of bleeding. So, what about if the patient has active bleeding during VTE? For example, the patient has active bleeding, severe bleeding, and at the same time, coincidentally, the patient has PE or DVT. In such case, actually, IVC filter is the choice. you have to insert IVC filter in such patient, which is temporary IVC filter, and then can be removed later on if the bleeding is controlled, and then you can start on Clexane 1 milligram 1 milligram per kg BD, and which could be easy to be reversed if any bleeding or recurrence of bleeding happen anytime. So in the case of active bleeding, IVC filter, temporary IVC filter, and also followed by Clexane 1 milligram per kg PD, so that if the patient develop any bleeding in time, can be reversed easily with protamine sulfate. Question 5 is history of malignancy. If the patient has any history of malignancy, before we used to use Clexane with a VTE with malignancy. Any vena thromboembolism with malignancy, we used to do Clexane. But recently, according to March 2020 recent NICE guidelines, they licensed, the first choice to be DOAC. So DOAC can be used in such patient with VTE with malignancy, DVT or PE with malignancy. DOAC is the first choice now, including Abixpan, dabigatran, rivaroxaban, and doxaban. But actually, the site and the size of malignancy could control or could change the choice of anticoagulation. For example, in the case of gastric carcinoma, dabigatran is not preferred at all because it might have minimal risk of bleeding or may carry minimal risk of bleeding in the case of gastric carcinoma. So again, this is very important because this is a recent guidelines on March 2020 on VTE with malignancy, DVT or PE with malignancy. DOAC is the first choice nowadays, according to March recent guidelines, modified recent guidelines on March 2020. The question number 7 is the patient pregnant or willing to be pregnant soon? If the patient pregnant, of course, the anticoagulation of choice at that time would be enoxaparin, which is Clexane, 1 milligram subcutaneous BD, 2 times daily, until the time of delivery, or until then for 6 weeks after delivery. So if the patient develop any PE or VTE or DVT during pregnancy, you have to use anticoagulation, which is Clexane, during the whole time of pregnancy and even up to 6 weeks after delivery. Clexane is the only licensed, anticoagulant now in DVT or PE in pregnancy. And after delivery, the patient can be shifted to warfarin, which is safe in lactation. What if the patient developed DVT or PE in the last trimester, like on months 7 or 8 or 9? At that time, you have to continue anticoagulation for total 3 months after delivery, total 3 months before and after delivery. Before delivery would be Clexane, and after delivery can be Clexane or warfarin, which is safe during lactation. So again, the anticoagulation of choice in a case of pregnancy is Clexane the whole time of pregnancy till 6 weeks after pregnancy. And if the patient develop VTE during the last trimester, you have to give the patient total 3 months of anticoagulation, including Clexane. And after delivery, the patient can start with warfarin, which is safe during lactation. And of course, if the patient is willing to be pregnant soon, you can choose Clexane, which is safe in pregnancy, so that if the patient develop any, if the patient get pregnant any time, it will be safe on her pregnancy. This is in brief the anticoagulation with choice, or which anticoagulation we have to start on in a case of confirmed DVT or PE according to the recent guidelines. This is present in our book, the recent book of acute respiratory medicine, and hopefully we are going to discuss other management, brief about other management according to the recent guidelines. Thank you all, and all the best. Thank you.